Very interesting for the first topic, and second topic also very, very interesting.
Okay, thank you everyone. Okay, so CBT I think is just the beginning here, and in the beginning you don't need to do a very small window. You just try a bigger one, and you can use the percutaneous principle, and you will easy to find the technique is not too difficult, and you can quickly to perform, and the result I think is very good. And the next time you will find I can smaller the window, and next time I can make it much more small. If you want to do the minimal invasive, if you want to have give the patient a better outcome or a good result, I think this is I think it's very good. For me, I have done this for at least 8 years. I never did a medical school again, so it replaced all my spine surgery. Okay, so the next topic here I will talk about the conventional fracture treatment, especially focus on the implant-based vertebral augmentation. Here we will also introduce the other original product by the Huang company. We call it the triple fix. I know this product is still available here, right? Yeah. So it's a original product by the Huang company. So, but today we will talk about how we deal with the patient with the vertebral conversion fracture. Yeah. When the vertebral conversion fracture we know is mostly happen in the elderly patient. In this patient have the conversion fracture, if we want to relieve the pain, sometimes we are suggesting to have the cement injection or the kyphoplasty to treat the compression fracture level. But after you do this procedure, sometimes you may have some physical effect on bones, including the central gravity shift. You inject too much cement, it will cause anterior column overload or induce the stress concentration over here, so it may have some impact on the adjacent level, the upper and the lower. So we call it a domino effect. So in the near future, patient will have a refracture and adjacent level fractures. So they will have a recurrent pain, right? I believe we all have experience like this. And for example, this is a 75-year-old female. You can see he visited our emergency department due to the low back pain. And the X-ray can find L45 has a fracture, maybe the compression fracture, but we don't know it's older or a new one under the MRI. In the MRI study, you can see the picture show it's a new compression fracture, but no spinal stenosis or no problem. So the patient received the cement injection at the first time, L4 and L5. But just 4 days later, he's still in the hospital, not discharged. And 4 days later, he got low back pain again. We are confused, so we check the X-ray. Okay, we found this level has a new fracture. You can see this is good, and this fracture happened. So we perform the second operation to do the for the one level, the vertebroplasty. 3 weeks later, he come back with low back pain. So you can see another level fracture happen. So yes, we do the third time. Finish? No. 3 months later, another one. Yeah. So you just keep collapse. But this time we don't do the surgery. We just suggest him to take the brace, lumbar brace, long brace, and with a painkiller. Because we cannot give him any guarantee or make sure it won't happen again. This 4th time. Okay? So this is it's an extremely case. So the patient's bone marrow, the DEXA the study, the bone marrow is around minus 4.0 or 3.7, 3.9 is a severe osteoporosis. So in this patient, especially elderly patient, the compression fracture always a big problem. Even the patient did not have any trauma injury, he just lift something heavy, it may induce the fracture, right? So according to the AO spine, the fracture classification system, you can divide the compression fracture into 5 types. Like the type 1 is just the bone marrow edema, but not the deformity. The type 2 is just the upper or lower ankle involved. Type 3, type 1, type 2, we call it a stable fracture. So you just need a conservative treatment. If the pain is too severe, some vertebral augmentation like the vertebroplasty can be done for the pain relief. But if the patient have the type 3 or type 4, type 5, the fracture dislocation, this we call unstable fracture. So this patient may need the surgery, include the pedicle fixation or even the cement injection, pedicle screw fixation to treat the fracture. Okay. So in other way, you can also try to use this scoring system. They give you some parameters and the grading, the points. So you can score in the patient. If the patient is from 0 to 5 points, I will suggest the conservative treatment is equal or not over 6 points. Then we suggest the surgical treatment. So what is the ideal management? Now it is still controversial, right? Because some patient can relieve the pain, even just take a conservative treatment. But when you receive a conservative treatment, it still can have some complication could happen, like the pseudoarthrosis, or you can aggravation, the kyphoplasty deformity will develop, or induce the second neurologic deficit. Even when you choose the surgical treatment, the screw instrumentation may have some implant failure risk or the screw loosening due to the severe osteoporosis. So what is the best treatment right now? It depends on the patient's condition. Like from the literature review, the NEJM 2009, they have a randomized trial to see the vertebroplasty is good or not for the osteoporotic spinal fracture. They found the patient received vertebroplasty was similar to the patient in the control group. It means even the patient received the vertebroplasty, is still the pain related disability is still similar to the conservative treatment. Okay, so, but in the other end, in the other side, the Lancet study in 2010 and 2016, they have 2 different randomized trials. They give the result tell us the vertebroplasty is superior to placebo treatment, especially for the acute fracture. It means less than 6 weeks. Yeah, in the first 6 weeks, the patient had the severe low back pain, and some patient cannot sustain the pain, and he will ask for further treatment, including the painkiller or brace or even the vertebroplasty, the surgery treatment. So if the patient has the acute fracture less than 6 weeks, you can choose the vertebroplasty to relieve the pain, acute pain for the osteoporotic patient. We all know use the vertebroplasty only can have the many complications that we should know about this. Some are very serious, including the wound infection, the nerve injury, or the cement leakage, and it cause the dural sac compression. Some cement will follow the venous system to the lung and cause the pulmonary emboli, and induce the respiratory failure. When I was a resident, it was about maybe 15 years ago, I was a resident. I have the experience like this. The patient just receive the vertebroplasty. After about not than 30 seconds, the O2 saturation just dropped, and very quickly. Then the patient's the heart rate slowed down. we we just pull up the patient and start the CPR, you know, because you may know that is due to the pulmonary embolism. It's very quickly. So if you want to use the vertebroplasty, you should keep in mind this may be a very serious risk. Cement extravasation maybe just around the vertebral body is fine. To the spinal canal issue, well, you should be very careful. But mostly from the review, in the vertebroplasty group, there are over 80% has a cement extravasation, but with the symptomatic cement leakage is not quite higher, but about 1% to 3%. Kyphoplasty can be a little lower, 0 to 0.3%. Okay, so adjacent level fracture, just like the case I just demonstrated, the subsequent fracture may happen, especially mostly within 2 months of vertebroplasty. So initially the patient received the vertebroplasty, we should give him a very good education, not to do something heavy, not to do any exercise, stronger exercise, or you should use the lumbar brace to protect your spine, or you may have another adjacent fracture, right? So some of the cause of induced adjacent level may be due to the unusual loading distribution, because we put the cement into the vertebral body. The cement volume may be a problem, and it may induce the stress concentration over here and to affect the upper level or lower level. Okay. So if we want to use the cement in vertebroplasty or kyphoplasty, the treatment goal all we need in the short term is try to make a stabilization of the vertebral body, especially we can relieve the pain, and so otherwise we should decrease the complication, right? And long term, we want to reduce risk of fracture and adjacent fracture. So what we can do in if we want to have this treatment goal, reduce adjacent fracture. So we may use some device for the vertebral body height restoration first, and create a space, releases pressure, and then we just put a cement injection to have optimal cement distribution in the vertebral body, and can help us to have a better surgical result. From the beginning, when we treat with the lower pain, we use just the cement and the needle to do the cement injection, but finally we have the vertebral kits, and then we have the balloon, the kyphoplasty, to do the cement injection. But right now, in the future, we are not just for the pain treatment. We are also concerned about the fracture treatment, the vertebral body height decrease. So we shifted to an implant-based mechanical vertebral augmentation. It means we can choose some product like the spine jack or the trapper fix or other product to make the disc height, to have the disc height restoration first, then do the cement injection. Maybe this can have a better result. So in this table, you can see the vertebroplasty group and the kyphoplasty group. Here we can see this is the group using the spine jack, and this is the 26 patient using the triple fix. You can see the height restoration ratio. These two devices have a very good outcome in the vertebral body height restoration ratio is around 12%, and triple fix can have an anterior height restoration over 80%. And you can see the adjacent level fracture risk. The adjacent level fracture risk, if you just use a vertebral plasty, you have in one year, 12 months, there are 43% may have the adjacent level fracture. Kyphoplasty over 30% patient. Even when you use the spine jack or the triple fix, the incidence rate is significantly lower. You can see it's about 10%, 6%. The triple fix, the 26 patient, 0%. But I think it means when you use before you perform the augmentation, you use the Implant-Based to restore the vertebral height. It can reduce the adjacent level fracture, right? So that's why we start to introduce you how to use the instrument, the triple fix. This product has two different sizes, diameter 5.0 and 5.8. It's a small one, it's a bigger one. So before the treatment, we should have the patient's X-ray or a CT or MRI image to have an actual view. So therefore we can make a measurement of the diameter of the pedicle wise and the length of the hips of the vertebral body. So they can help us to decide which size is better for the patient. Okay, because the diameter 5.0, the length is also different. So the triple fix is a product. It's the first one to focus on the wedge type fracture, compression fracture like this one. Anterior collapse, the posterior element is intact. The patient is about 70 to 80% patient with a compression fracture. They are all this type. So this one is the first product to focus on this type of wedge type compression fracture. It's a one-piece design, but you can expand it to a 3D triangular pyramid. Just like a tripod for the camera, the tripod, the shape, just like this. And this has another good benefit. If you put it into the vertebral body, expanding, if you find something wrong, you can restore and remove the imprint from use the instrument to remove it. So after expansion of the triple fix, then we inject the cement to make the augmentation in the body to have a very good result. And so the pressure has been expanded by the instrument. The pressure will be not concentrated. So this is different. Early stage we use the kyphoplasty, but when we put the cement, we need to remove the balloon first. Some patients, some vertebral part, some patient will collect again, and the cement will leak in different angle. So this is a procedure we can do the vertebral plasty, and the product is a spine jack and the triple fix. You can see it's a little bit different, but the procedure is almost the same. It's almost the same. It's a 2D expansion, it's a 3D expansion. Also, it's the whole kit includes the instrument. So this is the surgical procedure of the triple fix. You can use the trocar to find the pedicle line, to use the transpedicular approach. Then we use the guiding wire leave the guiding wire in the path. Then we use the drill to create a channel of the vertebral body, and then we use the reamer to enlarge the channel. Then just leave the implant insertion to the vertebral body and expand the implant to restore the vertebral body height first, and finally we just inject the cement. So you can see the picture here. This is the first step, and the guiding wire, drill, and the use the reamer to enlarge the channel, like this one. And then the implant, insertion the implant, expanding, like this one. And finally, after the injection, you can see the one level augmentation has been done. So you can see the video here. This is expansion inside the vertebral body. So this design is a triangular, 3D triangular. So it's especially suitable for the anterior compression fracture patient to restore the anterior vertebral body height. Okay. So using the implant-based vertebral augmentation can have the advantage that just we restore the vertebral body height first to have a good alignment, to improve the spine alignment. Then we just reduce the risk of cement leakage because we have to create a space over here. Then the leakage rate will be lower because we will not have too much stress concentration in the vertebral body. So you will reduce the rate of the adjacent level injury. Okay, this is cup angle change. You can see the cup angle change before pre-operation and post-operation after the implant and the cement restoration. And the 1 year's follow-up, you can see that the cup angle did not collapse again. So here's conclusion. Fracture should be treated by surgery. If a fracture is unstable, especially with intolerable pain. If you early treat, the more mobile bone, the better vertebral height you will receive. If you want to decrease the risk of refracture, the surgical approach achieve the height restoration and optimal cement distribution should need to be considered. The preoperative image study is required to assess the feasibility of the implant. So compared to the vertebroplasty and kyproplasty, implant-based procedure provide a fast and sustained improvement in pain and quality of life, reduce the risk of cement leakage. So here is just some experience that we don't do too much using implant-based, but if patient, because in Taiwan it's quite expensive, so if a patient need it or they are available to use the implant-based like the triple fix, we suggest him to restore the body height first, especially for a young patient. Some young patients are in the trauma condition. They can use the instrument to restore the body height first, and then use the cement for augmentation, and they will keep the alignment in a very good shape and prevent the further kyphotic change. Yeah. So okay. So this here is my talk about the augmentation.